Welcome to PGOG, postgraduate class in obstetrics and gynecology for postgraduates as well as consultants of obs and gynae. And today's topic is second part of diabetes in pregnancy, that is complications and management of diabetes in pregnancy. A short revision what we have seen in the part 1 of diabetes, because it is relevant complications as well as management of point of view. We divide diabetes in pregnancy in pre-gestational and gestational, but in gestational also it needs to be further divided into probable overt and pregnancy induced gestational diabetes mellitus. And what is probable overt is whenever the patient is having gestational diabetes mellitus, that is the diabetes has been identified or diagnosed for the first time during pregnancy. Associated with that, one of the four criteria: fasting more than 126, random more than 200 with clinical features, HbA1c more than or equal to 6.5%, or post glucose blood sugars after 75 gram 2 hours more than 200 milligram per dl. Anyone that will become as a probable overt. In the complications, pre-gestational or probable overt diabetes mellitus behave similarly. They have same complications. Underlying vascularity is more in these pre-gestational or probable as compared to the gestational diabetes mellitus. In GDM, macrosomia is the main complication in untreated women. Macrosomia related complications are, that is the reason macrosomia related complications are more in GDM, such as cephalopelvic disproportion, shoulder dystocia, birth trauma to baby and mother, and increase in incidence of cesarean sections. For overt diabetes mellitus, if we are asked about what are the complications, for postgraduate students, my request is, as far as possible, always try to classify the complications of any disease in pregnancy as antepartum, intrapartum, postpartum. In antepartum, further subdivided as first trimester, second and third trimester. Then what is the effect? These are the obstetric complications, or in other words, this is the effect of diabetes on pregnancy. Then second is, what is the effect of pregnancy on diabetes as a disease itself. Third, fetal complications, and fourth, neonatal complications. So if we divide, then we don't miss out on any of the complications. If together used, even in practical examination, if you are asked, what are the complications in a patient of diabetes complicating pregnancy? If you haphazardly start answering, you tend to miss out. That is why you should start as the complications can be divided as antepartum, intrapartum, postpartum, fetal, neonatal, and complications of because of the effect of pregnancy on diabetes. If we subdivide in that way, then it becomes easier to answer also in theory or in practical examination. First trimester complication is spontaneous abortion, and diabetic ketoacidosis is more commonly encountered in first trimester with the vomiting and sometimes hyperemesis also. Second and third trimester, hydramnios is more common. Why there is hydramnios? What is the explanation? Maternal hyperglycemia leads to fetal hyperglycemia. It is leading to fetal polyuria, and that is a possible reason why there is a increased amniotic fluid index or increase in the amniotic fluid in patients with diabetes mellitus. Second pathway can be the associated congenital malformation, especially open neural tube defects, which might also contribute to the increasing amount of the amniotic fluid. Preterm delivery is another complication in patients with diabetes, and in majority, more than 60%, prematurity is because one needs to terminate the pregnancy prematurely because of the associated complications. Hypertension in pregnancy and diabetes go hand in hand, and there is increase in all the types of hypertensive diseases in pregnancy, such as there is increase in preeclampsia, increase in gestational hypertension, increase in chronic hypertension, as well as chronic hypertension with superimposed preeclampsia. So all these four are showing a rise in patients with diabetes. In overt diabetes, there is a role of prevention of these hypertensive diseases in pregnancy by giving low dose aspirin, and the dose which has been given by SCOG is 81 milligram per day, and it should be started from 12 to 28 weeks, and it should be continued till delivery is the SCOG 2020 guideline. Intrapartum complications are mostly because of the macrosomia associated with diabetes, such as CPD, shoulder dystocia, maternal and fetal trauma, excuse me, cesarean sections, and postpartum hemorrhage. Postpartum complications, mainly puerperal sepsis, cesarean section, sepsis. Fetal complications, congenital malformations are more than double in patients with overt diabetes. Out of all these malformations, 50% are cardiac anomalies. If there is a caudal regression sequence, it is more specific for diabetes. That means it is this congenital malformation is rarely seen otherwise. It is 80 times more common with diabetes. That is why it is said to be the specific for diabetes, caudal regression sequence. More is a risk of anomaly, especially if the HbA1c level in first trimester is more than 9, then it is associated with more risk of congenital malformations. And the cause of this congenital malformation which is given is, though exact cause is not known, it is the oxidative stress associated with hyperglycemia in fetus, which leads to the development of these congenital malformations. Unexplained fetal death, it is one of the most, though not very common, but one of the most tragic complication. It is same, the prevalence is same in type 1 and type 2 over diabetes. Various reasons why there, or what are the risk factors for unexplained fetal death are, if it is uncontrolled diabetes where it leads to fetal lactic acidosis, and this fetal lactic acidosis leads to the intrauterine death. Whenever there is a maternal ketoacidosis is a risk factor for intrauterine death. Diabetes, and preeclampsia together are leading to intrauterine growth restriction is the risk factor for intrauterine death. And whenever diabetes is there associated with vascular complications, diabetic nephropathy, retinopathy, neuropathy, in these patients also there is an increased risk of sudden unexplained fetal deaths. There is altered fetal growth with diabetes. Intrauterine growth restriction can be there whenever a diabetes is with vascular complications, or whenever there is a congenital malformation along with the diabetes. IUGR is less common. What is more common is macrosomia. By definition, it is the birth weight of the baby more than 4 kg. What is the mechanism why macrosomia develops? Maternal hyperglycemia leading to fetal hyperglycemia. Fetal hyperinsulinemia. Insulin acts as a growth factor. There is more of somatic growth. Only brain is the only tissue which is not affected. Otherwise, there is a fat deposition in all the tissues in the fetus. Fat deposition is especially more around shoulders and abdomen, and that is the reason there is more of a possibility of CPD as well as shoulder dystocia. What are the neonatal complications? Respiratory distress syndrome is the complication which is mostly because of the preterm effect of preterm delivery. As we have already seen, preterm delivery is in more than 60% of the cases is indicated because of the associated complications, such as there can be a uncontrolled diabetes with preeclampsia, or there can be some abnormal fetal antepartum surveillance testing. So many a times this is a indicated preterm. What we need to understand or remember is effect of corticosteroids to improve lung maturity remains unaffected in spite of woman being diabetic. It is not that corticosteroids will not improve the lung maturity. The effect of corticosteroids will be good on the fetal lung maturity. Only problem with that will be there will be increase in the blood sugar, which needs to be controlled with the increasing dose of the insulin. Hypoglycemia in the baby is very common. Maternal hyperglycemia, fetal hyperglycemia leads to hypertrophy of pancreatic beta cells of the fetus. Fetal hyperinsulinemia is there, and this fetal hyperinsulinemia is the cause of neonatal hypoglycemia, which is defined as sugar less than 45 milligram per day. Hypoglycemia is more common in uncontrolled diabetes, and whenever the fetus is subjected to antenatal corticosteroid therapy. So in preterm diabetic, suppose we want to terminate the pregnancy, and then we give corticosteroids to improve lung maturity. These are babies who are more prone to develop hypoglycemia. Hypocalcemia is also there. The exact cause is not known, but some way diabetes affects magnesium calcium pathway in the baby, and neonates has hypocalcemia also as a complication. There is hyperbilirubinemia and polycythemia. Relative fetal hypoxia is there in diabetic babies, though there is macrosomia, baby has relatively fetal hypoxia, which is leading to polycythemia and hyperbilirubinemia. Cardiomyopathy, which is of hypertrophic type, is seen in the babies, but it usually resolves. It is temporary and rarely it leads to cardiac failure. Long-term cognitive development problem can be there in the diabetic neonate in the form of there is a possibility that there is an increase in autism spectrum disorder. If both the parents are have type 2 diabetes, there is a 40% possibility of inheritance to the baby, whereas it is less commonly seen with type 1 diabetes. Now, what is the effect of pregnancy on diabetes? Mother is already diabetic, whether pregnancy worsens the disease in some way. So your answer for that is if mother is already having diabetic retinopathy, then it progresses faster with pregnancy. So that is the effect of pregnancy, that already mother is having retinopathy. Then there will be faster progression of diabetic retinopathy. So that is the reason it is necessary to evaluate the patient at first antenatal visit for the presence of retinopathy. Repeat testing is to be done if retinopathy is present in each trimester to identify with features of progressive retinopathy at the earliest. Retinopathy might progress in pregnancy. Tight control of blood sugar helps in some way to reduce the chances of progression. And laser photocoagulation can be done in pregnancy as a treatment for this progressive diabetic retinopathy. Hypoglycemia is more common in diabetic pregnant women as compared to non-pregnant women. It is more common in first trimester when there is already reduction in the food intake with the nausea or sometimes with the hyperemesis. Hypoglycemia is usually leads in pregnancy is associated with late detection because pregnancy associated physiological changes producing the symptoms can confuse as patient feels uneasy, confused, or patient is having some tremors. Sometimes all these features can be taken by patient herself as feature of pregnancy, and that is that is why there can be a late detection. So one has to counsel and educate the woman about the possibility of hypoglycemia in pregnancy, especially early morning hypoglycemia is common, as we have already seen. Fasting blood sugar is always lower in the pregnant woman as compared to non-pregnant. With that, for some reason, she remains fasting for a longer time. Fetal consumption of the glucose goes on, and that leads to the possibility of hypoglycemia, uh, early morning hypoglycemia in women with overt diabetes. So we have to instruct the patient to keep glucose powder handy, and whenever she has a doubt, she should immediately take 3 to 6 teaspoons full of glucose in water. A third effect of pregnancy on diabetes is there is increased risk of diabetic ketoacidosis during pregnancy. Causes of diabetic ketoacidosis in pregnancy are in hyperemesis gravidarum. In patient mother has any infection, urinary tract infections, and even post-operatively there can be wound infections or there can be puerperal sepsis. So any infection is associated with increased risk of diabetic ketoacidosis. Sometimes there is insulin non-compliance. You put the patient on insulin with over diabetes and there is a non-compliance, and then patient comes to us with diabetic ketoacidosis. If patient comes in preterm labor and if we are using beta-mimetic tocolytics such as terbutaline or litotrine, then these drugs are leading to further rise in blood sugar, and sudden rise in blood sugar can lead to diabetic ketoacidosis. Similarly, corticosteroids are given to improve lung maturity. These drugs also are leading to sudden rise in blood sugar, and if it is not properly controlled with increasing the dose of insulin, then patient might go in diabetic ketoacidosis. Diabetic ketoacidosis in pregnancy occurs at lower blood sugar level as compared to non-diabetic and non-pregnant, and it occurs around 300 milligram per dl. Whenever the blood sugar reaches to 380 or more, then it can lead to diabetic ketoacidosis, or HbA1c 10% or more also is seen to be associated with increased risk of diabetic ketoacidosis. It occurs earlier because already pregnancy has features of starvation, accelerated starvation state, where the metabolism is shifting from carbohydrate to fat in the fasting state in the night. And so this starvation ketoacidosis also adds to the problem of hyperglycemia and diabetic ketoacidosis. So ketoacidosis, we need to be more vigilant for that and treat it aggressively if it is encountered, by taking the help of physicians in a timely manner. Complications pictorially we can remember. We start with the eyes, so that what is the effect of pregnancy and diabetes? At the top we have retinopathy. Apart from that, mother can have ketoacidosis, hypoglycemia, and infections. In infections, there can be urinary tract infection in antepartum period. Patient can have candidial vulvovaginitis, and puerperal sepsis or post-operative wound infection also can be there. Obstetric complications, we can remember first trimester increased risk of spontaneous abortions in uncontrolled over diabetes. In second half of pregnancy, both from hypertensive diseases in pregnancy and hydramnios. Intrapartum, can be preterm delivery and all the problems because of macrosomia. So what are the complications because of macrosomia? CPD, shoulder dystocia, intrapartum birth trauma to mother and baby. Postpartum complications are PPH, and there can be some increased infection, sepsis, puerperal sepsis, or wound infection. Fetal complications are congenital malformations, macrosomia, and less common is intrauterine growth restriction. Neonatal, increased risk of respiratory distress syndrome, hypoglycemia, hypocalcemia. Two are hypo, one is hyperbilirubinemia. and problems because of prematurity, such as baby even can have hypothermia. Now we start with the management. Management of gestational diabetes mellitus, where there is no probable overt diabetes. We have already seen in the first slide itself how we differentiate between a pregnancy-induced GDM and a probable overt DM. So if only pregnancy-induced GDM is there, then medical nutrition therapy and exercise forms the first line treatment in these patients. Blood sugar goals, whenever we treat the woman, are same as those for over TM. What are the goals are? Fasting should be less than 95, postprandial 1 hour should be less than 140, and 2 hours should be less than 120 milligram per DL. So you remember these three. For students, it is important to remember these three. Treatment goal is fasting less than 95, postprandial either 1 hour 140 or 2 hour 120 milligram per DL. Then once we put the patient on medical nutrition therapy and exercise, next is we need to repeat the testing after 15 days in a patient who is gestational diabetic. If after 15 days that these blood sugar goals are not achieved, fasting is more than 95 or 2 hour postprandial is more than 120, then in that case we have to start either patient on metformin or insulin, or third drug along with metformin, another one oral anti-diabetic drug which is being tried in recent years is glibenclamide. But what we need to remember is this: both of these, metformin as well as glibenclamide, these are crossing placenta and affecting the fetus, and these are not FDA approved. If we have started with say metformin and we repeat the testing after 15 days and still our treatment goal is not achieved, then it will be an indication to shift to insulin therapy. In the obstetric management of GDM, if patient is controlled on diet and exercise, there is no need of early termination. But we have to keep a watch on the fetal surveillance by educating the woman to keep the daily fetal movement count in the third trimester. Induction can be done by 39 weeks of pregnancy. Patient fails to deliver spontaneously till that time. But if patient is on insulin or there is uncontrolled GDM, then we admit the patient. We should admit the patient at 34 weeks. We have to do more vigilant fetal surveillance 3 times per week and termination by 38 weeks. Elective cesarean section for macrosomia will be indicated whenever the fetal weight is estimated fetal weight by ultrasonography is more than 4 or 4 to 4.5 kgs. Diet in diabetes mellitus is also called as medical nutrition therapy or MNT, which is same for gestational diabetes mellitus and for pre-gestational or overt diabetes. A patient has to split her food intake in 6 parts, where there are 3 moderate meals and 2 to 3 small snacks at regular intervals are to be taken, so that it leads to a moderate rise in blood sugar after each meal, and there are never periods of sudden hyperglycemia and sudden fall in blood sugar. What is recommended is a patient has to take 55 to 60% of carbohydrates meal should have, and carbohydrates should be as far as possible complex carbohydrates. Sugar and jaggery, these are simple carbohydrates. Honey, these are to be avoided, and what we need to have is a complex carbohydrate, means carbohydrates which are present in rice, wheat, or in our pulses. Fat intake should be up to 25% and saturated fat should be less than 10%. Again, saturated fat is oil, whatever oil we are ingesting, it should be less than 10%. Protein intake needs to be increased in pregnancy as such as well as in diabetic women, and it should be 20 to 25%. Diet, if it is fiber rich, it leads to the less absorption of sugar, from intestines, and it helps in the glycemic control. Less carbohydrates leads to is why we want to reduce the carbohydrate intake is there is a risk of macrosomia keeps on reducing. Now, Federation of Obstetrics and Gynecologic Society of India 2021 has given MNT guideline, medical nutrition therapy guideline in greater detail, where calorie requirement in pregnancy is given as per type of work. What is the type of work a lady is doing accordingly? Sedentary work, then the calorie intake should be 2250 kilocalories per day. Moderate work, 2850 kilocalories per day, and heavy work, it should be 3200 kilocalories per day. Now, one word of caution is suppose a patient is a homemaker, that doesn't mean that she's not working. Work is not only the job or what the profession she's doing. What you have to find out is, say from a rural area, she's fetching water from a long distance, she's definitely doing heavy work. So that is the reason we have to take the history and then decide what type of work, her routine work includes, whether it is sedentary. That sedentary is where she is sitting on a chair and doing some work. Moderate work where she is standing for a long time, and heavy work where she is lifting the heavy weights or she is walking long distance. Then it will be heavy work. Calorie requirement is also decided as per the woman's body mass index. And for BMI, for Indian standards, the lower values are there. Underweight is less than 18.5 BMI, where calorie intake will be more. So that whatever as per work has been calculated, say she has a moderate work, 2850. Another additional 500 kilocalories per day needs to be added. Normal and overweight is there, that is 18.5 to 22.9 and 13 to 24.9 BMI. Then there is no need to add or subtract the calories. But if a woman is obese more than 25 BMI, then calorie requirement as per work minus 500 kilocalories per day. So 500 needs to be subtracted in that case. This is for Indian women, but internationally, how we categorize the degree of obesity as per BMI is normal weight is less than 25, 25 to 29.9 is overweight, 30 to 30.9 is obese, and morbidly obese is 40 or above, more than 40 BMI. And accordingly, as per the country of origin, you have to see which standard needs to be followed. But remember that underweight woman, you add calorie 500 kilocalories per day, and obese woman you subtract the calorie. Another thing is you see what type of work a woman is doing. So my request to all the obstetricians is, to consultants as well as to postgraduate students is, whenever we are sending the patient to dietitian, just don't send her and say that she has diabetes and give her a diabetic diet. You yourself see what type of work she is doing, what is her BMI, and accordingly you write how many kilocalories per day a woman should be given, and you also give split of carbohydrate, fat, and protein to the dietitian. Dietitian might be knowing, but it is better to have the clear instructions given to the dietitian, because medical nutrition therapy is the first line treatment for gestational diabetes mellitus, as well as it plays a major role to control blood sugar in over diabetic also. So that is the reason we need to be more careful. Otherwise, what I have seen in my career is we are just sending the woman to dietitian, and so many times dietitian is not even taking cultural considerations, food habits, and she is just giving a stereotype food chart to the woman which she cannot practically follow. She might be a lady who cannot afford so many things given in the chart, and that is the reason just that chart remains on paper, and medical nutrition therapy is a failure in that case. And that is the reason we also as obstetrician need to be involved whenever we are formulating the diet for these pregnant women. Management for the over diabetes can be divided as preconception care, first trimester care, second trimester care, third trimester care, intrapartum care, and postpartum care. Again, you are asked in practical examination about this, or if you get a theory question, remember that if you divide management in compartments like this, then you don't miss out on any point. For any disease, not only diabetes, for any disease, if you divide the complications or you divide the management like that, it becomes easier. Preconception care of over diabetes is mainly it helps in reducing the early pregnancy loss, and more important is there is a reduction in congenital malformations also. Strict glycemic control is necessary whenever a woman is planning pregnancy. HbA1c goal is less than 6.1%, and one can ask the patient to avoid pregnancy if her HbA1c is more than 10%, as risk of congenital malformations is very high in these women. If she is already on insulin, fasting should be between 100 to 120 milligram per day, and postprandial should be 120 to 140 milligram per day is the goal before she takes a decision to plan for the pregnancy. No pregnancy should be unwanted or unplanned in a over diabetic woman. In preconception only, evaluation and treatment of retinopathy or nephropathy should be done, and we need to educate the woman about the increased risk of obstetric complications whenever there are vascular complications in a overt diabetes. Folic acid supplementation should be started at least 3 months before conception with a dose of 400 microgram per day, and it should be continued in the first trimester to further reduce the risk of congenital malformations. We need to stop oral drugs except metformin whenever she is planning pregnancy, and start her on insulin. That is safer, because so many times it happens that with diabetes, if there is already obesity and PCOS and she has irregular cycles, the detection of pregnancy might be late, and already whatever damage is done, because the damage is there because of the other oral anti-diabetic drugs which are not safe in the pregnancy, will already be there, and that to overcome that, we need to stop the oral drugs except metformin, and we should start insulin whenever she is planning pregnancy. Now, what I have seen in practice is we get less women who come to us as a preconceptional counseling, even if she has a diabetes. But whenever a woman comes to us with infertility, as a general rule, consider it as an opportunity to do the preconception testing as well as counseling. As an obstetrician, we should grab it as an opportunity and do the complete investigations as well as counseling of the woman whenever she comes, even with subfertility or infertility or with any other complaint, before she conceives. In the first trimester care, hospitalization whenever she is over diabetic, and the main role of hospitalization is in patients counseling and education. Pregnancy dating should be done, because so many times we need to terminate the pregnancy earlier, and this pregnancy dating will be helpful. Then we have to evaluate for vascular complications by 24-hour urine protein for detection of microalbuminuria as a first feature of diabetic nephropathy, serum creatinine, retinal examination, and echo is indicated, maternal echocardiogram, if patient mother has diabetes as well as essential hypertension. Aneuploidy screening in the first trimester is by pregnancy associated plasma protein A and beta HCG and nuchal translucency. These three are used for the as markers for the aneuploidy screening. But remember that in diabetes, the levels of PA, PPA and beta HCG are lower as compared to non-diabetic women, and that is why we need to be more cautious whenever we are interpreting the results. Even if the result is at the upper limit of normal, then also we need to be more vigilant, and we have to see for nuchal translucency which is not affected by diabetes. Cell-free fetal DNA will be helpful in these women, which is a non-invasive test for the fetal aneuploidy screening. Then once we hospitalize, we decide the dose of insulin which is required for her. Patient education for strict glycemic control is necessary, and we have to educate her about features of hypoglycemia also. Diet advice also needs to be given, and we have to see to it that she understands and follows whatever medical nutrition therapy is advised to her. In the anti-diabetic treatment in pregnancy, oral anti-diabetic drugs are usually avoided except metformin. Insulin form still is a mainstay drug in over diabetics complicating pregnancy. Insulin and metformin, there are some studies which are showing that the outcome is better as compared to insulin alone. If woman is using insulin pump, or she is taking multiple insulin injections per day, the studies have shown that the outcome is safe. Outcome is not getting affected whether she is taking multiple insulin injections or she is on insulin pump. Monitoring is done by capillary glucose level by glucometer, and we have to educate the woman and see to it that she does it correctly. This self-monitoring by glucometer. Now, what is important is we need to discharge the patient, because otherwise it is very difficult for the woman to follow the diet advice. If you say that she has to take 6 meals per day and you hospitalize her, it is not feasible for the woman to follow the diet advice also. So we need to educate her to use for the correct use of glucometer and for self monitoring. And initially it should be done at say 7 times at fasting, and after before and after every major meal, and also in the middle of the night by 3 a.m. is the time which is allocated to see whether there is a early morning hypoglycemia. And once the diabetes is under control, it can be done 4 times, that is fasting and after each major meal. If woman can use and afford, and if it is available, continuous monitoring devices and infusion pumps together are giving a result just like having an artificial pancreas. It is called as artificial pancreas because the uh, control is perfect if woman is using continuous monitoring devices and infusion pump. In pregnancy, there is a daytime hyperglycemia and there is a night hypoglycemia that we need to remember while we are adjusting the dose of insulin. Insulin requirement usually reduces in first trimester because of the pregnancy associated nausea and vomiting. But as the pregnancy progresses in second and third trimester, there is progressive increase in the insulin requirement in a over diabetic woman. Insulin doesn't cross placenta. That is a major advantage. That is so that it is not leading to fetal hypoglycemia. Short acting or intermediate acting insulins can be used, such as Actrapid and Mixtard. Intermediate acting insulins are preferred for the evening dose to prevent hypoglycemia at night or early morning hypoglycemia. Usual starting dose of insulin is 4 or 6 or 8 units before each major meal. So 3 times a day as per postprandial blood sugar. If postprandial blood sugar is 120 after 2 hours, postprandial is after 2 hours. If it is 120 to 160, then 4 units is given 3 times a day. 160 to 200, then 6 units. And more than 200, then 8 units 3 times a day is given is the approximately we can remember this way how much insulin to be started. Usually we start 4 units 3 times a day, but provided the postprandial 2 hours is between 120 to 160. If the value is higher, we have to start a higher dose of insulin. Then we need to, after every third day, we have to titrate and increase the dose by 2 units if the goal of this insulin treatment is not achieved. And the goal is same as for gestational diabetes mellitus. Fasting should be less than 95. Postprandial after 1 hour should be less than 140, and after 2 hours it should be less than 120 milligram per dl. Every third day, then once the diabetes is under control, every third day fasting and postprandial blood sugar should be done as a self-monitoring by glucometer by the patient herself. Metformin in pregnancy is safe. So there are so many studies where it has been given in women in first trimester, second and third trimester, and it is found to be a safe drug. We start with 500 milligram 2 times a day is the starting dose with the same goal of the fasting less than 95 and 2-hour postprandial less than 120 milligram per DL. Dose can be increased if this is not achieved and maximum dose is 2 grams per day. Side effects are nausea, vomiting, loose motions, and with a the greater dose, lactic acidosis is a serious complication, and rarely the higher dose can lead to hypoglycemia also. Capillary blood glucose goals in pregnancy in over diabetes, which is done with the help of glucometer. I am again repeating it. These are we have already seen in the last slide. Fasting less than or equal to 95. Pre-meal less than or equal to 100. 1 hour post-meal less than or equal to 140. 2 hour post-meal less than or equal to 120 milligram per DL. And HbA1c less than or equal to 6%. Now, if the woman at the start of the pregnancy has severe diabetes, uncontrolled diabetes, sometimes if we go for this HbA1c less than or equal to 6%, the chances of she having episodes of hypoglycemia increases. So, in such women, we can keep a value of 7% as the goal. Hypoglycemia, serious hypoglycemia is when the sugar is less than 40 milligram per DL. We need to start the treatment whenever the sugar is less than 70 milligram per DL to avoid serious complications such as coma or convulsions with a severe hypoglycemia. In the second trimester, maternal serum alpha fetoprotein plus anomaly scan is done from 16 to 20 weeks of pregnancy. But again, maternal serum alpha fetoprotein level in diabetics mothers is reduced, and we need to be cautious while interpreting the report. Fetal echocardiogram is indicated to rule out congenital cardiac anomalies, which is usually done from 20 to 24 weeks of pregnancy. Usually, as pregnancy progresses, insulin requirement keeps on increasing. So, second trimester insulin requirement is higher as compared to the first trimester, which is normal. But for some reason, if insulin requirement falls and the fall is more than or equal to 15%, it is considered as a feature of placental insufficiency in second and third trimester, and it indicates that the baby will be having intrauterine growth restriction, and overall there is a bad prognosis if the insulin requirement falls in second or third trimester. In the third trimester, fetal monitoring should be done from 32 to 34 weeks. Daily fetal movement count, biophysical profile, CTG monitoring at least 2 to 3 times per week, and in uncontrolled even it can be done on daily basis. Pregnancy is usually terminated by 38 to 39 weeks because we know that unexplained fetal deaths IUDs are there, and that is why we don't wait for the spontaneous onset of labor for a longer time. But because we do not have a respiratory distress syndrome as a complication, we wait till 38 weeks in a woman who has a controlled diabetes. But earlier termination is indicated for uncontrolled diabetes. Caesarean section will be indicated for macrosomia, uncontrolled diabetes, or a woman having other obstetric indications such as previous caesarean section. So overall caesarean section rate is found to be around 80% in over diabetics complicating pregnancy. Short-acting insulin is better in intrapartum care of the woman, and we have to give sufficient IV glucose and insulin infusion pump whenever we are planning induction of labor. More details about intrapartum management are we don't give we give evening dose of insulin, but we withhold the morning dose. Then we have to infuse normal saline intravenously at the rate of 100 ml per hour, and we measure glucose every hourly. And as per the glucose level, we add insulin to this normal saline. If glucose level is between 90 to 120, insulin is not added. 120 to 140, 2 units are added. This is called as titration of insulin titration of normal saline. Normal saline titrated with insulin. 140 to 180, add 4 units. More than 180, add 8 units. So 144 is there, 4 units. 122 is there, 2 units. And 180, 8 is there, 8 units. I have remembered this way. You can also have your own way of remembering. More than 120, less than 1, but less than 140 is 2 units. 140 to 180 is 4 units. More than 180 is 8 units. Now, when the woman enters into active labor, or if glucose levels are less than 70 milligram per day, suggest you are going for hypoglycemia, change the intravenous fluid from saline to 5% dextrose. This is important. Otherwise, unnecessary, there will be hypoglycemia. You are treating hypoglycemia along with other complications, intrapartum complications. So 5% dextrose is given at 100 ml per hour, and similar titration is done as per the blood sugar level with a target glucose level of around 100 milligram per day. This is important intrapartum management if the woman is already on insulin. In puerperium, insulin requirement, once baby delivers and placenta comes out, insulin requirement drastically reduces after delivery. Insulin is usually not required for first 24 to 48 hours. We can do the intermittent testing, and fractional dose of insulin can be given as per the blood sugar level for 1 to 2 days to avoid sudden hypoglycemia. Oral drugs can also be started in the puerperal period. One has to be cautious to prevent infections, as wound infections are more with uncontrolled diabetes, and proper contraceptive advice needs to be given. In the postpartum follow-up, 75 gram oral GTT should be done after 4 to 12 weeks of delivery. And if it is normal, still it needs to be repeated every 1 to 3 years, because we know that woman, even patient has gestational diabetes, risk of developing diabetes is more in the next 20 years. Evaluate for metabolic syndrome, because these women are more prone to go for metabolic syndrome, and risk of repeat diabetes in subsequent pregnancies of about 50%. Thank you so much.